Welcome to this ABC Vascular Ultrasound video lecture on the lower limb venous system, ultrasound anatomy and identification of the abdominal and thigh vein. The main deep veins of the thigh are the common femoral vein, the profunda femoral vein, and the femoral vein, previously called the superficial femoral vein. All these deep thigh veins are adjacent to a satellite artery, therefore we have the common profunda and superficial femoral arteries. The main superficial vein of the thigh is the great saphenous vein. The great saphenous vein communicates with the deep system by joining the common femoral vein through the saphenofemoral junction. To identify the common femoral vein, position the transducer in cross-sectional view in the groin, and you will identify the common femoral artery, the common femoral vein, and the great saphenous vein. This is the so-called Mickey Mouse and represents the saphenofemoral junction. From the common femoral vein, you can see the great saphenous vein, which leaves the common femoral vein and continues in the medial aspect of the thigh. Looking carefully at the saphenofemoral junction, we can see here the saphenofemoral junction, the terminal valve, which is typically located at this level, and then we have the origin of the great saphenous vein and the anterior accessory saphenous vein. These two veins can share a common origin, or they can have a separate one. If we focus our attention on the great saphenous vein, we can see that there is the terminal valve over here, and by moving the transducer in longitudinal further down, we can identify another valve. This is the preterminal valve. The great saphenous vein continues from the groin down through the medial aspect of the thigh and calf. To identify the great saphenous vein, use a transverse view and move the transducer all the way down in the territory of the great saphenous vein in the thigh and in the calf. The great saphenous vein presents with a typical appearance in which the saphenous compartment mimics the Egyptian eye. It is contained within two fascias. There is the saphenous fascia, which is the more superficial one, and there is the other fascia, which is deeper and is the apneuretic deep fascia. This is the typical appearance of the superficial veins, which are the great saphenous vein and the small saphenous vein. Starting from the groin, move the transducer further down to identify the venous femoral bifurcation. We can see the arterial bifurcation first, and then more distally, there is the venous femoral bifurcation. Thus we can see the femoral vein and the profunda femoral vein. By moving the transducer back to the groin using a longitudinal view, we can better appreciate the anatomy of the femoral bifurcation. Again, we can see the common femoral vein here that divides into the femoral vein and profunda femoral vein. You can see that the arterial bifurcation has already divided, and we can see that the common femoral vein is just posterior to the superficial femoral artery. You can probably better appreciate this using color flow. You can see that the venous femoral bifurcation is more distal compared to the arterial bifurcation. From this level, move the transducer further down distally into the thigh to identify the femoral vein. The femoral vein lies posteriorly to the superficial femoral artery, and you can appreciate this both in cross-section and longitudinal views. This is an important landmark, especially in the presence of pathology. Therefore, we have arterial flow superiorly compared to the venous flow. This will be different when we approach the calf veins, where the popliteal vein is actually superior compared to the artery.
Hi, and welcome to this ABC Vascular Ultrasound case study on the ultrasound features of inguinal deep vein thrombosis in intravenous drug users. Addiction to intravenously administered drugs is a serious epidemiological problem with several health-related complications. Deep vein thrombosis are the most common and serious one in this cohort of patients. Deep vein thrombosis in intravenously administered drug users are often found at the level of the groin, present as a mass. This is due to the use of groin puncture as a common site to obtain intravenous access. There are several distinctive ultrasound features of the deep vein thrombosis in this cohort of patients that can be recognized. In this video case, we're going to analyze each of these distinctive ultrasound features. The common femoral vein is the most common site for injecting intravenous drugs. The common femoral vein is therefore often found to be damaged, collapsed, or stenosed in these patients. As you can see in this example, there is a focal region of collapsed common femoral vein with thrombus extending into the distal common femoral vein. The proximal femoral vein and profunda femoral veins are patent with spontaneous echogenicity, which is indicative of venous stasis due to proximal obstruction. Another distinctive ultrasound feature that the operator should be familiar with when scanning this type of patients is the presence of an acoustic shadow at the level of the groin, often found at the level of the puncture site. This shadow is caused by the presence of scarring tissue and represents the main limitation when trying to identify the common femoral vein. The acoustic shadow can be observed in a longitudinal and cross-section view as an anechoic band caused by a high reflector such as the scarring tissue. It is useful to identify the more distal part of the common femoral vein when the proximal region is not identified. This is another scenario of a deep vein thrombosis of the distal common femoral vein and proximal femoral vein. The common femoral vein, when identified, can present damages such as wall thickening or anechoic regions next to the wall as an inflammatory disease. The common femoral vein can be atresia, small in caliber, often presenting a smaller caliber than the satellite artery. Deep vein thrombosis can extend into the iliac vein, most commonly into the external iliac vein, where chronic alteration of the thrombus can be observed, such as scarring or fibrotic thrombus. Distinctively acute thrombotic occlusion of the iliac veins are rare and usually develop on top of already pre-existing chronic alterations. The presence of a long-lasting damage of the vein and therefore occlusion leads often to the development of a groin venous collaterals network, which can be observed using color Doppler flow, often at the level of the common femoral vein. In conclusion, there are several ultrasound features that the operator must be familiar with when scanning deep vein thrombosis in intravenous drug users patients, which are the presence of acoustic shadowing, covering the presence of the common femoral vein. The common femoral vein can present several damages, including collapse region or stenosis, and it is the most common site of collateral venous flow, which can be observed with color Doppler flow. Thanks for joining ABC Vascular Ultrasound. Hi, and welcome to this ABC Vascular Ultrasound case study, ascending thrombophlebitis of the gray saphenous vein with partial deep vein thrombosis of the common femoral vein. This is a case of a 30-year-old female patient that attended accident emergency for ongoing pain, tenderness, and redness of the thigh and calf. An ultrasound investigation was therefore requested. The first step is to perform intermittent compression ultrasound maneuver at the level of the groin, where the common femoral vein is visible alongside with the saphenofemoral junction. The intermittent compression demonstrates a partial compression of the common femoral vein. The intermittent compression ultrasound maneuver is therefore performed throughout the course of the gray saphenous vein. The gray saphenous vein is not compressible when applying gentle pressure over the transducer. This is due to the presence of an obstructive thrombus, which is visible on the B mode imaging. We then can move the transducer back into the saphenofemoral junction to better assess the borders and extension of the thrombus. The thrombus is hyperechoic, well attached to the wall of the gray saphenous vein, with extension into the saphenofemoral junction and proximal region of the common femoral vein. As the thrombus within the common femoral vein was limited to the region adjacent to the saphenofemoral junction, it was considered as an extension of the great saphenous vein thrombosis. The distal region of the common femoral vein was patent and compressible. The patient was therefore diagnosed with a chronic ascending thrombophlebitis of the great saphenous vein with extension into the deep venous system, causing partial obstructive deep vein thrombosis. Thanks for watching ABC Vascular Ultrasound. Hi, and welcome to this ABC Vascular Ultrasound case study, Deep Venous Reflux of the Popliteal Vein. This is a case of a 52-year-old female patient that was diagnosed with an isolated popliteal vein deep vein thrombosis. The 6-month ultrasound demonstrated patency and incompetency of the popliteal vein. Using B-mode image, we can demonstrate that the vein is compressible. The lumen of the popliteal vein is echo-free, there are no scarring thrombus, and we can see the popliteal artery underneath the popliteal vein. By applying color Doppler flow, we can confirm the patency of the vein, and by applying dynamic maneuver such as distal cuff compression, we can provoke the venous flow, and once we release the cuff, we can see evidence of reflux, which appear as red, considering the current color scale settings. To measure the length of the venous reflux, we use pulse wave Doppler. First of all, we obtain a basic information of the venous flow, which appears phasic. We then apply distal cuff compression and cuff release, and we can see that there is a greater than 1 second reflux of the popliteal vein. In conclusion, the popliteal vein, it is patent with no residual thrombosis, and it is incompetent with deep venous reflux greater than 1 second. Thanks for watching ABC Vascular Ultrasound.
Hi, and welcome to this ABC Vascular Ultrasound video lecture on ultrasound carotid anatomy. In this video lecture, we will talk about the anatomy of the carotid arteries, positioning of the transducer for the identification of the carotid arteries, and the ultrasound anatomy of the common carotid artery. The cerebral vascular system is fed by three main supraaortic vessels, which are on the right the innominate artery, on the left the common carotid artery, and the subclavian artery. The innominate artery divides into the common carotid artery, which branches into the internal carotid artery and the external carotid artery. The right subclavian artery arises off the innominate artery and gives off the vertebral artery. The left common carotid artery generally arises off the aortic arch and divides into the internal and external carotid arteries. The left subclavian artery usually arises off the aortic arch and feeds the left vertebral artery. The ultrasound appearance of the arteries is peculiar. An artery appears on ultrasound as an anechoic tube bound by two hyperechoic structures. The anechoic part of the tube represents the arterial lumen, which is anechoic, and is indicated by the red arrows in this video. The hyperechoic structures are the posterior and anterior walls and are made of three main layers. These are the intima, media, and adventitia. The intima is the innermost layer and is in contact with the arterial lumen. The adventitia is the outermost layer, and in between these two layers lie the media, which is hyperechoic. The ultrasound appearance of the artery using a transverse plane is different from the longitudinal one. In transverse view, the artery appears as a cross-sectional area as indicated by the yellow circle. As in the longitudinal view, the lumen is anechoic while the walls are hyperechoic. In the next section of this video lecture, we will demonstrate how to position the transducer on the neck of the patient and the ultrasound appearance of the anatomical landmarks used to identify the carotid arteries. Transducer positioning. To identify the common carotid artery, position the transducer using a transverse view in the medial aspect of the neck, between the sternocleidomastoid muscle and the trachea. When positioning the transducer at this level, the proximal region of the common carotid artery will be visualized. The main anatomical landmark used to identify the common carotid artery is the jugular vein. The jugular vein is of larger caliber compared to the common carotid artery. It is located anteriorly and laterally to the common carotid artery, and it is easily compressible when applying gentle pressure over the transducer. As illustrated in this video, the jugular vein walls collapse when pressure is applied over the transducer, while the common carotid artery remains patent. In addition to the jugular vein, there are other anatomical landmarks that can be used to identify the common carotid artery. These include the thyroid lobes on both sides, which are adjacent to the common carotid artery, the sternocleidomastoid muscle, which is contained within the muscular fascia superiorly with respect to the common carotid artery, the trachea, recognizable by the hyperechoic structures of the cartilage, and on the left side there is another anatomical landmark, which is the esophagus. To summarize, the common carotid artery is adjacent to the thyroid lobe, to the side of the trachea, below the sternocleidomastoid muscle, and adjacent to the jugular vein. These are the main anatomical landmarks used to identify the common carotid artery. While the origin of the common carotid artery can often be visualized using ultrasound, the left common carotid artery origin may not be visualized for anatomical reasons that we will now show you. Let's start from the right side. Once the common carotid artery has been identified in transverse view, move the transducer down towards the very base of the neck, angling the transducer downwards as shown. At the base of the neck, you can visualize the innominate artery. This artery is a large vessel that arises off the aortic arch and divides into the common carotid artery and the subclavian artery, and therefore the origin of the right common carotid artery can be identified. The origin of the left common carotid artery may not be visualized. First, identify the origin of the common carotid artery in transverse view. The jugular vein, the thyroid lobe, the esophagus, and the sternocleidomastoid muscle can be visualized. move the transducer down towards the base of the neck, tilting the transducer downwards. An acoustic shadow will appear on the screen. This shadow is caused by the clavicle and represents the main obstacle to visualizing the origin of the left common carotid artery. A complete steal occurs when both the systolic and diastolic blood flow are retrograde through the vertebral artery, which is ipsilateral to an obstruction, or a severe stenosis of the subclavian artery or the innominate artery on the right side. Therefore, the direction of the blood flow within the vertebral artery will not be antegrade as it should normally be. The two main ultrasound diagnostic criteria to use for the identification of a complete steal of the vertebral artery are the color Doppler flow appearance and the pulsed wave Doppler waveforms of the affected vertebral artery. In the absence of pathologies, the common carotid artery and the ipsilateral vertebral artery present with the same color Doppler flow appearance. Thus, if red on the color bar indicates arterial flow, both the common carotid artery and the vertebral artery will appear in red, while the vertebral vein will appear in blue. In presence of a complete steal, while the common carotid artery will appear in red, the vertebral artery will appear in blue, thereby indicating the different direction of the flow through the vertebral artery compared to the ipsilateral common carotid artery. A second criterion used to confirm the presence of a complete steal of the flow through the vertebral artery is the Doppler waveform. Simply obtain a Doppler waveform from the vertebral artery and observe the direction of the flow. In this example, the vertebral artery Doppler waveform is below the baseline and therefore indicates that the flow is directed away from the transducer. This criterion is used to confirm the color Doppler flow findings. When we compare the vertebral artery Doppler waveform with that obtained from the ipsilateral common carotid artery, we can see that the directions of the waveforms are opposite to each other. The vertebral artery waveform is below the baseline, while that of the common carotid artery is above the baseline.
Hi, and welcome to ABC Vascular Ultrasound case study Intracranial Occlusion of the internal carotid artery. In this video case, we'll show you what are the diagnostic criteria to suspect the presence of an obstructive intracranial carotid disease. We start the assessment using color flow of the common carotid artery. Using the transverse mode, we optimize the mode first, therefore we reduce the size of the box, we keep the box straight, and we start the assessment of the common carotid artery. We move the transducer up towards the bifurcation of the carotid artery, and you can note that there is not a good color filling despite lowering the scale. We lower the scale as low as we can to better the color filling. However, we can see that there is still some filling defect within the internal carotid artery. Only part of the lumen it is filled with color flow, whether the remaining part of the artery is not filled with color flow. At the bottom right corner, you can see what a normal internal carotid artery should look like. Therefore, the points we gained so far using color is that there is a poor color filling of the internal carotid artery and the common carotid artery. This is probably indicative of very low velocity throughout the internal carotid artery, and to confirm that the low velocity, we used a very low scale to identify low blood flow velocities. We continue the assessment using the longitudinal mode. Therefore, we turn the transducer, we optimize our color box, we steer the color box parallel to the flow direction. We still have a very low scale, and we then apply the pulse wave Doppler. With the pulse wave Doppler, we obtain a Doppler waveform which is quite unusual for a common carotid artery. This Doppler waveform is high resistance and there is not a diastolic flow pattern, with evidence of a small reversal flow in delayed systole. The normal waveform of a common carotid artery is a low resistance waveform with evidence of a well-represented diastolic flow. The absence of a diastolic flow is indicative of distal high resistance, likely caused by an obstructive disease. We continue the assessment into the external carotid artery, and we confirm the anatomy by using the Doppler mode. Therefore, we place the sample volume within the origin of what we think is the external carotid artery. You can see that we have a normal high resistance waveform. We can confirm that this is the external carotid artery by applying the tapping maneuver, and we can see that there is alteration of the diastolic flow. We now continue the assessment into the internal carotid artery. By using color flow only into the internal carotid artery, we can note that again there is not a complete filling and the pattern of the color is alternating. You can see alternating of color patterns such as red and blue patterns. This again is indicative of distal high resistance territory. However, the brain is a low resistance territory. Therefore, these findings are suspicious of the presence of distal obstructive disease. In a normal condition, there is a continuous filling of the internal carotid artery. You can see here the difference between a normal pattern of the color flow and abnormal pattern of the color flow. We apply the pulse wave Doppler again, and we can see that we are obtaining an abnormal waveform with evidence of reversal flow in the late systole. This is also called a stump flow and is a typical finding in the presence of an intracranial obstructive disease, which could be either a severe stenosis of the intracranial carotid artery or actually an occlusion. You can see here the difference between the normal internal carotid artery with velocity which are within the normal ranges, and in our case the velocity are very low, suggesting again intracranial obstructive pathology. Therefore, the take-home messages from this video case is that color flow abnormalities such as alternating pattern of a color flow may be indicative of distal obstructive pathologies at intracranial level, and the kind of a stump flow that we notice within the internal carotid artery is also indicative of a distal obstructive pathologies. Remember that you can only make a suspicion of intracranial obstructive disease. The patient will later need of a further imaging for the intracranial circulation, which will confirm the diagnosis or perhaps not. Thanks for watching ABC Vascular Ultrasound. Hi, and welcome to this ABC Vascular Ultrasound case study, Internal Carotid Artery Chronic Occlusion, B-mode and color Doppler flow appearance. This is the B-mode transverse view of the common carotid artery, which presents echo-free lumen. As we approach the carotid bifurcation, we can see the internal and external carotid artery. While the lumen of the internal carotid artery is not echo-free, the lumen of the external carotid artery appears anechoic, therefore echo-free. We repeat the same assessment using color Doppler flow. We set the color scale very low. We can see that there is good color filling of the common carotid artery, while there is not color filling at all in the internal carotid artery. The external carotid artery appears patent with good color filling. To confirm this, we use a longitudinal view, and we can see absence of color flow throughout the internal carotid artery despite a very low color flow scale. The external carotid artery is patent with good color filling. Thanks for watching ABC Vascular Ultrasound.